පළවෙනි මාස 3න් පස්සේ පළවෙනි මාස 3 ෆෝලික් ඇසිඩ් ඊට පස්සේ
ඔව් ඊට පස්සේ පළවෙනි මාස 3 දැන් අර ડોක්ටර් මට මාර ප්‍රශ්නයක් වෙලා තිබ්බේ මට දින මතක තිබ්බේ නෑනේ මේ මොකද අපි එහෙම බබෙක් බලාපොරොත්තු වෙනකොට හිටියේ නෑ ළමයි 3ක් හිටියනේ ගෙදර ළමයි දෙන්නේ ගෙදර ඉන්නවා ඉතින් මහත්තයාටත් හරියට රස්සාවක් නෑ ඒ නිසා ළමෙක් බලාගෙන නම් හිටියේ නෑ මේ කාලේ ඉතින් ජීවත් වෙන්නත් අමාරුයිනේ එතකොට ඒගොල්ලන් මේ මට තිබිච්ච ප්‍රශ්නේ දැන් මේ මුත්‍රායක එකපාර පොසිටිව් වෙච්ච ගමන් මේ දින දන්නේ නෑනේ ඊට පස්සේ දින බලන ස්කෑන් එකක් කරා මුලින්ම ක්ලිනික් එකට ගිය වෙලේ ඔව්
ඒකෙදි මේ දින ගැන මොකද කිව්වේ
ඒ ස්කෑන් එකේ බලලා තමයි ස්කෑන් එකේ බලලා ඒ ડોක්ටර් කිව්වා දැනට සති 10යි දවස් ගාණක් වෙනවා අම්මා ඊට පස්සේ ඔයාගේ දිනේ වෙන්නේ ජූලි මාසේ 9 වෙනිදා තමයි කියලා තමයි අද දිනේ දුන්නේ
එතකොට ඊට පස්සේ ආයි අම්මා ස්කෑන් එකක් කරානේ නේද සති 5ේදී
සති 5ේදී ස්කෑන් කරන්නේ නැහැනේ ડોක්ටර් මම හිතන්නේ අපේ හොස්පිටල් එකේ සති 5 ස්කෑන් කරන්නේ මාස 5 ස්කෑන් එක. ඔව් මාස 5 ස්කෑන් එක කරා. මාස 5 ස්කෑන් එකේ එහෙම මුකුත් ගැටලුවක් වෙන්නේ නැහැ. බබා හොඳට ඉන්නවා කියලා තමයි කිව්වේ. පුතෙක් කියලා කිව්වා.
එතකොට දැන් ඊට පස්සේ මුකුත් ප්‍රශ්න තිබ්බේ නැහැනේ හොස්පිටල් එකට එන්න. ඒ ස්කෑන් එකෙන් පස්සේ
මොන වගේ ප්‍රශ්නද ડોක්ටර් අහන්නේ?
ඒ කියන්නේ සීනි එහෙම ප්‍රශ්න තිබ්බේ නැහැනේ. ආයි සීනි එකක් බලන්න නැතිනේ ලේවල්.
කොයි කාලෙද ડોක්ටර් ඔය සීනි එකක්
බලන්නේ? 28 දී විතර.
ඔය මුලදී සීනි එකක් බැලුවා. ගිය ගමන් මම මුල් දවසේ සීනි එකක් බැලුවා. ග්ලූකෝස් බොන්න දීලා. ඒකේ ගැටලුවක් නැහැ කිව්වා. ඊට පස්සේ ආපහු සති 28 දී ග්ලූකෝස් පීලා පරීක්ෂණයක් කරා. ඒක බොන්න බෑ ડોක්ටර් හරි අමාරුයි. වමනෙත් ගියා මට භාගයක් බොනකොට.
එතකොට දැන් මේ පාර හොස්පිටල් එකට ආවම එන්න කියලා දැන් ඇඩ්මිට් වෙන්න කිව්වේ දින හරියි කියලානේ අම්මට මොකද බඩේ අමාරුවක් එහෙම මොකද තිබ්බේ නෑනේ
නෑ එහෙම අමාරුවක් නැහැ මම ඇත්තටම ක්ලිනික් එකට තමයි ආවේ මට ඇඩ්මිට් වෙන්නත් බෑ ડોක්ටර් ළමයි දෙන්නෙක් ගෙදර ඉන්නවනේ දෙන්න බලා ගන්න විදියකුත් නැහැ ඉතින් ඒ නිසා
දෙන්න බලා ගන්න කවුද දැන් ඇඩ්මිට් උනේ
දැන් ඉතින් මහත්තයා තමයි මේ දවස්වල බලාගන්නේ
එතකොට ඔයා ජොබ් එකක් කරන්නේ නැද්ද
නෑ මම මොන ජොබ්ද ડોක්ටර් ඉතින් මේ ළමයි දෙන්නෙක් ගෙදර ඉඳගෙන කොහොමද ජොබ් කරන්නේ
එතකොට මහත්තයා ජොබ් එකක් කරනවද?
ඔය යාට තින් ස්ථිර රස්සාවක් නැහැ. ඔය කුලී වැඩක් තමයි කරන්නේ. කුලියක් මලියක් කරගෙන තමයි ජීවත් වෙන්නේ. ඉතින් එහෙම ස්ථිර රස්සාවක් නැහැ.
එතකොට මට මේ පොඩ්ඩක් කලින් අම්මගේ ප්‍රෙග්නන්ට් එක ගැන කියනවාද? කලින් ළමයි දෙන්නේ හම්බුණා කිව්වනේ. එතකොට
ඔව් මම මේ 4 වෙනි පාටනේ දැන් ප්‍රෙග්නන්ට්
4 වෙනි පාර.
ඔව්
3 වෙනි පාරට පළවෙනි එක නන්නකෝ.
පළවෙනි එක නා ડોක්ටර් මේ ළමයා නැති වුණා.
ඊට කලින් පළවෙනි ළමයා නැති වුණාද?
පළවෙනි ළමයා නැති වුණා. ඔව්.
සති කීයේද වගේද නැති වුණේ?
සති 10ක් විතර වගේ ડોක්ටර් මාස 3ක්වත් ගියේ නැහැ මේ අපි ඉතින් ප්‍රෙග්නන්ට් කියලා දැනගත්ත ගමන් ડોක්ටර් කෙනෙක් ඇල්ලුවා VOG ඇල්ලුවා. අල්ලලා ස්කෑන් එකක් කරගත්තා මේ ළමයා එතකොටත් හැදිලා නැහැ කියලා කිව්වා. හෘද වස්තු වැඩ කරන්නේ නැහැ කිව්වා.
එතකොට දෙවෙනි ළමයා මේ එතකොට ඒ පළවෙනි ළමයා නැති වුණාට පස්සේ බඩ හොදලා ඒක එහෙම එකක් කරා.
ඔව් පෙති දැම්මා පෙති දාලා පෙතිත් එක්ක අයින් වෙලා ගියා. ඊට පස්සේ කිව්වා මුකුත් දැන් නැහැ ප්‍රශ්නයක් නැහැ කියලා. බඩ සේදුවේ නැහැ. පෙති දැම්මා විතරයි.
එතකොට දෙවෙනි ළමයා හම්බුනේ සීස කරලාද?
නෑ දෙවෙනි කියන්නේ පළවෙනියට හම්බෙච්ච ළමයා එයා නෝමල් හම්බුනේ.
එතකොට එයාගේ බර කීයක් වගේ තිබ්බද?
එයාගේ බර තිබ්බ 2.400ක්.
එතකොට එයා ඉපදෙනකොට වෙන මොකුත් ප්‍රශ්න තිබ්බේ නැද්ද? ලේ වැඩිපුර ගිහිල්ලා එහෙම මොකුත් ප්‍රශ්නයක් තිබ්බේ නැද්ද?
නෑ මොකුත්ම ප්‍රශ්නයක් තිබ්බේ නෑ ડોක්ටර්.
එතකොට දැන් අනිත් බබා හම්බෙනකොට
දැන් ඉන්න දෙවෙනි බබා.
ඔව් දැන් ඉන්න දෙවෙනි බබා.
ඔව් ඒ බබාගෙත් මොකුත් ප්‍රශ්නයක් තිබ්බේ නෑ හම්බෙන්න ගිහිල්ලා.
එයාත් නෝමල්ද ගත්තේ?
ඔව් නෝමල් තමයි හම්බුනේ.
බර කීයක්?
එයාගේ බර තිබ්බ 2.800ක්. එයාගේ බර හොඳයි. දුවගේ බර හොඳයි.
එතකොට එයා ඉපදුනාට පස්සේ ලේ යන මුකුත් ප්‍රශ්න තිබ්බේ නෑ නේද?
නෑ එහෙම මුකුත්ම ගැටලුවක් තිබ්බේ නෑ. මම ඉතින් දෙවෙනි දවසේ ගෙදර ගිහලා ළමයිගේ වැඩත් කරගෙන හොඳට මහත්තයාගේ වැඩත් කරගෙන හොඳට හිටියා.
එතකොට දැන් මේකෙදි දැන් ඇඩ්මිට් වෙන්න කිව්වම දැන් ගෙදර තව ළමයි දෙන්නෙක් ඉන්න හින්දා බලා ගන්න එක තමයි තියෙන ප්‍රශ්නේ නේද?
ඔව් ඉතින් බලා ගන්න එක ප්‍රශ්නයක් නේ ડોක්ටර්. අපිට ඉතින් අම්මලා තාත්තලාත් නෑ. අම්මා මේ මිනිස්සුත් එක්ක මම පැනලා ගියා කියලා ගෙදරින් කවුරුත් මට සලකන්නේත් නැහැ. ඉතින් අම්මලා තාත්තලා බලන්නෙත් නැහැ. ඉතින් අපි දෙන්න තමයි කොහොම හරි ළමයි බලාගෙන ඉන්නේ. දැන් ඉතින් ළමයි දෙන්නව බලාගෙන.
වියදමත් වැඩි නේද? මේ
ඔව්
දවස්වල.
වියදම වැඩිනේ ડોක්ටර්. ඉතින් කොහොමද කුලියක් මඩියක් කරලා ජීවත් වෙන්න මේ දවස්වල බැස්සත් එක්ක එහෙන්. මනුස්සයට ප්‍රස්තාවකට යන්න විදියකුත් නැහැ. ප්‍රශ්න තමයි ડોක්ටර්. ලොකු පුතා දැන් ඉස්කෝලේට දැම්මා ගිය අවුරුද්දේ දැන් ඒ ළමයට පොතු ලිස්ට් එකකුත් දැන් මේ සැරේ ගන්න කියලා ඇවිල්ලා. හරි ප්‍රශ්න ડોක්ටර්.
හරි අවුරුදු.
ડોක්ටර්ට පාස් මෙඩිකල් හිස්ටරි පාස් සර්ජිකල් හිස්ටරි ඇලර්ජිස් එහෙම මොනවාරි අහන්න ඕන නම් අහන්න.
අම්මට මොන හරි ඇලර්ජික් තියනවද?
ඇලර්ජික් කියලා ડોක්ටර් නිකන් මොන වගේ?
ඒ කියන්නේ කසල පළු දානවද මොන හරි බෙහෙතකට හරි
නෑ කෑමට අර එකපාරක් ඉස්සොල්ට නම් එහෙම ආවා. ඊට පස්සේ මං ඉස්සෝ කණ එක නැවැත්තුවා. ඉස්සෝ දැන් කන්නේ නැහැ.
එතකොට මොන හරි කලින් මීට කලින් සර්ජරි මොන හරි ඔපරේෂන් කරලා තියෙනවද?
ඔපරේෂන් නෑ. එහෙම මුකුත් කරලා තියෙනවා ડોක්ටර්. මං පොඩි කාලේ මගේ නියපොත්තක් ගැලවිලා ඒක මේ ඔපරේෂන් කරලා තියෙනවා.
නෑ මොනවත් ලොකු ඔපරේෂන් මුකුත් කරලා නෑ නේ.
බඩේ ඔපරේෂන්ද ડોක්ටර් අහන්නේ?
ඔව් බඩේ ඔපරේෂන්.
නෑ බඩේ ඔපරේෂන් මුකුත් කරලා නෑ.
එතකොට මීට කලින් තාමන හරි අම්මට ලෙඩ එහෙම මොනවත් බෙහෙත් දවස ගානේ බෙහෙත් බොන ලෙඩ මුකුත් එහෙම මුකුත් නෑනේ.
නෑ. ඉතින් අපි හොඳට මේ වත්ති පිටියේ වැඩ කරලා නෑ අපි හොඳට වත්ති පිටියේ වැඩ කරලා ඉන්න මිනිස්සුනේ ડોක්ටර්. එහෙම ලෙඩක් නෑ ඉතින් අපිට.
එහෙම රැතුම ඒ වගේ ලෙඩ මුකුත් නෑනේ.
නෑ මුකුත් නෑ. දැන් ආවට පස්සේ මොන හරි කරාද කියලා වගේ දැනගන්න ඕනේද ડોක්ටර්ට?
දැන් හොස්පිටල් එකට ආවම මොනවද කරන්නේ? මොන හරි ડોක්ටර්ස්ලා ස්කෑන් කරාද?
ඔව් ස්කෑන් එකක් කරලා බැලුවා. ලොකු ડોක්ටර්ත් ආවා. මේ ස්කෑන් එකක් කරලා බැලුවා.
හොඳයි කිව්වද?
ඔව් හොඳයි කියලා කිව්වා. පුතා
බබා හොඳට දඟලනවද?
ඔව් හොඳට දඟලනවා. ඔව්.
බබා මේ මොන පැත්තටද
පටියකුත් ගත්තා. ඔව්.
බබා මේ මොන පැත්තටද ඉන්නේ කියලා කිව්වද? යට පැත්තට දොළුව තියෙන හැම මොකද?
ඔව් බබා හැදලා කියලා කිව්වා ડોක්ටර්. ඒකනේ ඒගොල්ලන් නෝමල් ගන්න පුළුවන් කියලා කිව්වේ නැත්තම් මම බයේ හිටියේ. Right? Okay, good. Very good, Bodhini. Thank you. And now the time is 8:20. So this is the time you start. Then this is the time you finish your history. Okay, it's very good. So you took only 10 minutes, right? So shall we discuss a little bit about your history, right? First of all, I would say thank you, and you took that challenge. So that's how it should be, right? So it's not easy, right? The people listening may be thinking that I could have taken the history better than this, and she would have done these mistakes and all. But I would say, as a beginner, it was a good history. There was some, I mean, the flow was not that ideal, right? Time to time you jump from one part to the other part without completing that part, right? So they were like that. The flow was not that very good. However, the contents overall was there, right? So the content were there, but the flow was not that good, okay? So when you are taking that kind of a history, so first of all, the introduction. So nama mokadda, vayasa kiyada, kohe idan dawi job ekak karanawada. Key blood group ekak, so you can ask the same time the blood group also le varge mokakda. Then key when part of the pregnant vela tiyenne, which pregnancy is this? That you have to ask at the beginning. You didn't ask that thing, Daru. So you have to ask which pregnancy is this? So the mother will say this is the 4th pregnancy. Then you ask how many kids you have. Then 2 kids. That is your introduction. So how will you present your introduction? My patient is, or is, shall all of us write down this history? Take about 5 minutes and write down what you have heard here. So you write down on your piece of paper and somebody has to present it. Take about 5 minutes and try to complete it. Please switch on your cameras just to have, live discussion, that's all. You don't have to write write long sentences, just write down in a summarized manner, and you can present. So at the end of this exercise, you will be really benefited, believe me, right? Trust me. So you will be benefited really with this exercise, right? You can present. This is a good exercise that, right? You can do mistakes. That's okay, completely okay, right? Because she took that challenge, and as a beginner, within 10 minutes time, she was able to complete the history. So that's good. That means if you practice, you can do it in 5 minutes time. So you have more time for your discussion. So you will get more marks. Who would like to present, Davi? Hasangi, would you like to present? He is free.
Yes, sir.
Okay, good. Yeah.
So I got interrupted between the second part of Bodhini's history taking, but I'll present. I don't know whether my readings are
Okay.
correct or not. Regarding,
Okay, that's fine. That's fine. I mean, whatever you have heard, right? You
okay,
just present in a history manner, as a presentation. You do your presentation. It's okay, right?
okay, sir. Shall I
Yes.
start, sir?
Wait. Just give me 1 second. Now the time is 8:29. So you are going to start at 8:29. We will see how long will it take for you to present it. Okay? Yes, Hasangi. Go ahead.
So you
So
want me to,
as suppose you are in the exam setup, I'm your examiner. Okay. So you are going to present your patient to me. Okay. Right. Yeah.
so
Go
is
ahead.
it the summary or the entire history?
No, you go with the full history.
Oh, okay, sir.
You prepared a summary.
Yeah.
You can expand your summary and you can present.
Yeah, okay, sir.
Yeah.
Sir, my patient is 36 years old, mother of 2 children, in her 3rd pregnancy, admitted to the hospital for the labor. Baby is in cephalic
For the
presentation.
delivery or
the
the confinement.
yeah,
He
for the
admitted for the
confinement.
confinement or the delivery. Okay. Right.
For the confinement, and baby is in cephalic presentation, and so far the pregnancy is uncomplicated.
Okay then. So I think you have the summary with you. Okay.
Yeah,
So
sir.
shall I ask somebody else to present their history and then you present your summary? Is that
Okay.
okay?
Yeah.
Right, good. Right. So who would like to present the history? Who would like to present the history? Lakni, would you like? Lakni Jayasuriya? G35? Okay. Yes, go ahead. Okay, so you are going to start at 8:30, right? Yeah. Yeah. I can't hear you, Daru. Can you make some noise? Okay. Anyway, thank you for taking that challenge, right? So try to sort out that this issue with your computer, right? So Bodhini, would you like to present that history? Okay. Yes, right. Yeah. So you're going to start at 8:32. Now it's 8:32. Start your summary. Not summary, sorry, history.
My patient, Kamani, a 36-year-old mother of 2 children, came from Vallavatta, presented to the hospital for the confinement at her 4th pregnancy. Her pregnancy up to now was unremarkable, and her first pregnancy was a miscarriage at 10 weeks, and her second and the third pregnancies were normal vaginal deliveries without any complications. And her past medical history and the surgical history was unremarkable, and also she has no allergies to any drugs and the food. And I didn't.
Yeah, are you presenting the summary or the history? I need a history. Then later we'll go to the summary. History means you have to present everything, like, as you mentioned, right, you start with the introduction, then presenting complaint, then analysis and past obstetric histories, first trimester dating, first trimester what happens, second trimester, third trimester, and after admission what happens. That is his history. What you're going to tell me is the summary now. I want the history. Would you like to restart, or has anybody prepared a history? Luckily, now your problem is sorted out. Maybe I may be deaf, I don't know, but I can't hear your voice. I think this problem. Who would like to? Even a boy, okay. Take this opportunity, right? Don't take it serious, right? We all are in the learning curve, right? So it's not a big issue, right? Yes, I think it's going to work now. See, now you can. Lakshmi, talk. Who else? Who else? Who else want to present this history? Nirasha, would you like to? Ruvini, Dev, Welhena. Anyone? Take this opportunity, Daruvane, right? Don't take it serious. You can do mistakes. It's okay. And this is our first class, first practical class, right? So you can do mistakes. It's okay. No one is perfect. Okay, shall I present the history? So this history you have to present in this way. Now, when you are going to present your history, Daru, so you have to keep your hands like this on the table. These things also matters. These small things also matters when it comes to the exam. So you have to keep your hands like this on the table, or else you can keep your hands on your lap, right? Don't do like this. This irritating the examiners, okay? So don't do like this, right? You keep your hands like this. Good, you can keep your hands like this and keep your back straight, or else you can keep your hands on the table with a piece of paper on your hand, okay? That is one thing. And when you're presenting, Darwani, sorry, when you're presenting, you have to always maintain the eye contact with the examiner. Don't look at your papers throughout and present. Then it's going to be boring. Okay? So if you look at the examiner's face and if you have eye contact with the examiner, two things happen. One is it shows that you are a confident person. You are not lying. A liar cannot maintain the eye contact throughout. Okay? So if you are maintaining the eye contact with the examiner, that means that you are a confident person. That's one thing. That is one of the key things they are going to assess in the exam. Other thing is, when you are keep maintaining your eye contact with the examiner also will be embarrassed. And even if you miss something, they won't pick it up. Right? Now, if a girl comes in front of me and looking at my face always, I will be embarrassed. I will not, remember what she told, something like that. We all are human beings. Same thing happens, okay? So that is very important. That is, again, gives you more marks, right? So always try to maintain the eye contact. If you can't maintain the eye contact throughout, what you have to do is, you look at your paper and look at the examiner time to time. But most of the time, you try to maintain the eye contact with the examiner. Remember things inside, put into that sketch and try to present, okay? So keep your hands like this. Look at the examiner's eyes and maintain the eye contact. And when you are present in Darwani, you have to have very clear voice, especially girls, right? Your voice may be too soft sometimes, so that the examiner cannot clearly listen to your voice, hear your voice, okay? So it shouldn't be something like that. No, not that way. You have to have a good tone, talk bit loud, Okay, and you don't have to be, 100% fluent in your language, but what you are saying should be very clear. Okay, and the things that you want to highlight, you have to highlight then and there. So I would present this patient's history in this way. Okay, suppose you all are my examiner, so I would present like this way. Good evening, sir. I'm going to present my obstetric history. My patient is, I would start saying that my patient is. Don't say this woman. Girls, would you like if someone comes and tell you, would you like it? No, no one like. So always respect the dignity of the patient. Say, my patient is Mrs. Okay, so you can say, my patient is Mrs. Shriyani Pereira. She is 36 years old. She is 36 years old. The thing 36 is not at the normal age where the most of the people become pregnant. Okay, 36 years. So you have to highlight that thing. So my patient is Mrs. Shriyani Pereira. She is 36 years, mother of 2 children in her 4th pregnancy. Okay, mother of 2 children in her 4th pregnancy. She is from Vellavatta area and she is a housewife. Her blood group is O positive. That is my introduction. My patient is Mrs. Shriyani Pereira. She is 36 years old lady. 36 years old lady from Vellavatta area. And she is a mother of 2 children in her 4th pregnancy. Okay. And she is a housewife. Her blood group is O positive. That is all about my introduction. Then she presented with, or she admitted for the confinement at 40 weeks. She admitted for the confinement or the delivery. Don't say labor, Dargo. She admitted for the confinement or the delivery at 40 weeks. Now it's clear. Okay. Then what next is the analysis of your presenting complaint. Now, when a patient admitted for the confinement, there is nothing analyzed. You have to analyze, right? Because the date is, now it's due date and she admitted, that's all, right? So you can start then now this is a pure and simple history, obstetric history, antenatal history. So if you want, you can start with your past obstetric history at the beginning. So you tell the examiner, sir, I would like to start with my past obstetric history. As I mentioned earlier, this is a 4th pregnancy. The first pregnancy was unfortunately ended up in the first trimester miscarriage where it was managed medically. Her second pregnancy was antenatally uncomplicated and she had a vaginal delivery. However, the baby's birth weight was 4.6 kilograms at term. Is that significant? Yes, that is significant because low birth weight baby in the first pregnancy. Her third pregnancy was antenatally uncomplicated and she had a vaginal delivery and the birth weight of the baby was 2.8 kilograms. Now you have talked about the past obstetric history and there are things that you have to highlight. First pregnancy was a miscarriage managed with medically, and second, the first baby was low birth. That is important. Now, introduction given, past obstetric history you have mentioned because that gives good flow to your history. Then you can start talking about the current pregnancy. Then you tell the examiner, sir, now I would like to talk about the current pregnancy. This was an unplanned pregnancy, now preconception. This was an unplanned pregnancy. You didn't ask about folic acid, probably she would have not taken folic acid preconceptionally. This was an unplanned pregnancy and mother was not certain about her dates. And she had a booking visit, fortunately, during the first trimester, where her dates were confirmed by ultrasound scan, where the ultrasound expected date was given, that is today. So she is now 40 weeks. Now talk about the booking visit. She had a booking visit around 10 weeks, where the history, examination, and the investigations done, all were said to be normal. As I mentioned earlier, she had a dating scan, and this estimated date was given according to the ultrasound scan. First trimester was uncomplicated, especially I asked about any bleeding or any fever history, but the patient denies. From the second trimester onwards, she was put on iron and calcium supplements. Tetanus toxoid she didn't ask. So probably she would have had 1 dose of tetanus toxoid. And she had an anomaly scan around 20 weeks and patient was reassured it was normal. So you talk and you leave a gap for the examined thing. Around 28 weeks, patient had her routine diabetic screening, and according to the patient, it was said to be normal. And up to now, she had regular clinic visits, and the pregnancy was uncomplicated, and she was asked to admit because today is the due date. Now, what happens after admission? After admission, she had ultrasound scan and she was reassured the baby is normal. Probably she had a CTG and the patient again reassured, and she was told that they are going to, so whatever the plan. If they say, okay, we can wait 3 more days, then you can say, patient was said that they are going to wait 3 more days for her to go into normal labor. If not, they are going to start the induction process. So something like that. After admission, what happened? Okay, that is her pregnancy. Then talk about past medical history. Her past medical history was uncomplicated and no past surgical history, significant past surgical history. You don't have to mention about that nail removal, those things, those are immaterial, right? No significant past surgical history. And her social history. She's a mother of 2 children. There are 2 kids at home and they are also young kids. So there is no one to look after the kids. And the husband has to look after the kids. So she's very worried about the kids at home. So she wants to go home as soon as possible. Right? And her husband is a manual laborer. They don't have a stable income. And the income is about 40,000 per month. That is not enough for their expenditures. So that's the financial constraints also there. Okay, right? And she is not willing at the moment for any, want to stay in the hospital for a longer time. She wants to go home and come back when she's going into labor by her own. So you can mention that thing also there. That is her social history. Okay, clear? That's the whole history. So you start your introduction. So I would say, my patient is Mrs. Triani Pereira, 36 years old mother, 36 years old mother. As they look at the exam, 36 years old mother in her 4th pregnancy with 2 living kids. Her blood group is positive and she is a housewife from Vellavat area. She admitted at 40 weeks for the confinement. So I would like to start with her past obstetric history. As I mentioned earlier, this is the 4th pregnancy. First pregnancy was unfortunately ended up in a miscarriage, first trimester miscarriage, which was managed medically. Second pregnancy and third pregnancy you can combine together. Second and third pregnancy were uncomplicated antenatally, had vaginal deliveries. However, birth weight of the first baby was 2.4 kilograms and the second baby was 2.8 kilograms. Okay. Now, sir, I would like to talk about the current pregnancy. This was an unplanned pregnancy where the patient has not taken any preconception of folic acid. And patient is uncertain about her last menstrual period. So the estimated date of delivery was given by an early scan. She had a booking visit around 10 weeks where the history, examination, and routine investigations done, and according to the patient, all were said to be normal. Her first trimester was uncomplicated. I specifically asked about fever, bleeding, but the patient denies. Okay. From the second trimester onwards, she was put on iron and calcium supplements. Tetanus toxoid, 1 booster dose was given, and around 20 weeks, she had an anomaly scan. And the patient was reassured that the baby is doing well. Around 28 weeks, patient had diabetic screening, and according to the patient, it was said to be normal. Following that, she had routine clinic visits, and the pregnancy had been uncomplicated so far. She admitted now at 40 weeks for the confinement. After admission, she had a scan and it's confirmed the baby is turned, cephalic presentation, and the CTG was taken. Patient was reassured, and she was told that they are going to take the induction process in about 3 days' time. Okay, her past medical history and past surgical history was uncomplicated. No significant drug history, drug allergies. How your patient gives a history of allergic to some food items like prawns. Socially, she's a housewife. Husband is a manual laborer. They are financially not stable. The income, monthly income is about 40,000. That is not enough for their expenditures. And there are 2 kids at home. They are also younger kids. They can't look after them by their own. So the patient is very worried about that. And the husband has to look after the kids at home. So he is losing his job during this hospital stay. And patient doesn't want to stay longer in the hospital because of these social issues. She wants to go home and come back when she going into labor. That's your history. Can you do that? Have I seen looking at any paperwork? No. You can just think about you can put the history into that format and then present. If you present in that way, without looking at your paper, that shows that you are a very confident person. Even if you miss something, right, they won't punish you, they won't deduct mark from you. That is very important. And take a deep breath. Everyone. Now, this is for you all to present your summary. Now, can you all present your history in that way? Yes, we will discuss time every week, like we will have a discussion like this, and you can practice further. Okay. Now, Hasarangi, you can present your summary.
Yes, sir.
Yes.
Good evening, sir. I would like to explain my summary to you. So my patient is 36 years old, mother of 2 children at home, presented in her 4th pregnancy to the hospital for the confinement, sir. Her first pregnancy was first trimester miscarriage, which was managed conservatively, and her second and third pregnancy.
So far, your summary was good. Your introduction, first sentence was good, but don't dilute your summary. Now, when it comes to summary, you can't tell all these unnecessary detail like manage medical miscarriages and all. So you don't have to mention those things because that is not going to change your management. Okay, right, good. So do it again from the beginning.
Good evening, sir. I would like to present my summary to you. My patient is 36 years old, mother of 2 children in her 4th pregnancy, presented to the hospital for the confinement. Her first pregnancy was first trimester miscarriage, and her second and third pregnancy were normal vaginal delivery. However, the second pregnancy, she had to deliver a large baby which weighed
2.4, small baby, not large baby.
So the third one was the large one, sir.
It's not large, Daru.
2.8
means the normal. 2.5 to 3.5 is the normal birth weight. Okay. So first baby had a low birth weight, but the second baby normal birth weight.
Okay. So the second pregnancy, however, the second pregnancy, her delivery was a small baby with the low birth weight. She has some social and financial issues as well, sir.
So before that, you can tell about this pregnancy. Anything significant?
So far, it's uncomplicated.
This pregnancy was ultrasonically dated pregnancy. Antenatally, so far uncomplicated. Isn't it? Yes?
Yeah.
Then you can say she has some great financial and social issues with regard to this pregnancy.
Yeah.
So you don't have to elaborate further because this summary, you can say financial and social issues with regard to this pregnancy. Okay. So you can use about 3 or 4 sentences. That's all your summary. That is good. Now what you have done is good, Daru. So so somebody else would like to present your summary. Luckily now your technical issue is sorted out. No. I think there's some Bhuta dosha there in your room. That may be the reason. Well, Hanan, Dev, somebody would like to present your summary, Daru. Do it right. Don't worry, you can do mistakes. It's okay. Yes, Bodhini, would you like to present your summary again?
A 36-year-old mother of 2 children came from Vellavata, presented to the hospital.
Vellavata is not it's not needed. Fine. Yes.
She presented to the hospital for the confinement at her 4th pregnancy, and up to now her pregnancy was antenatally unremarkable and ultrasonically dated pregnancy. And her first pregnancy was a miscarriage, and second and third pregnancies were normal vaginal deliveries, and without any postpartum complications. And her past medical history, surgical history, and allergic history was unremarkable. And
if they were unremarkable, you don't have to mention that. Right? Yes.
However, she has social and financial problems.
Okay, right. So try to combine those sentences. You can say 36 years old, mother of 2 children in her 4th pregnancy, at 40 weeks admitted for the confinement. Antenatally, this was ultrasonically dated pregnancy, otherwise uncomplicated so far. The past two pregnancies were vaginal deliveries, where the uncompleted vaginal deliveries. However, first baby was low birth weight at term. She's having social and financial issues with regard to this pregnancy. That is your summary, 3 sentences. Okay, I hope most of you can do the summary now. It's very good. When you are presenting your summary, Daru, only the age is necessary. You don't have to mention where the patient is coming from, what kind of professional, and those things are not much important when it comes to the summary. Important positive and important negative things. Okay, then formulate your problem list. Now you have to list.
So I have a question regarding this. The last sentence, can we say that the patient is having some social and financial issues since this is an unplanned pregnancy?
Yes, that's good. You can say, you can add the word unplanned pregnancy also there. Yes, good. That's much better than, she's having the social and financial issues. You can say, since this is an unplanned pregnancy, she is having social and financial issues. So that gives an idea to the examiner that this is unplanned pregnancy and she is having these problems as well.
Okay, sir. Thank you, sir.
Yeah. Yes. Have your problem list. Yes, Lakshmi, your summary, what you have sent me is okay, right? It's fairly okay summary. Good. Problem list. Who would like to present your the problems? Let's check in. Yes, who would like to present your problems? I want everyone to at least open up your mouth and talk a bit. Okay, that's very important for you all to build up your confidence, right? Yes, who would like to present your problems? Okay, whoever it is, you can present your problems. Okay, Bodhini, shall we start now? Since this is your case, right? We'll start with you, right? So, yeah, tell me, what are the problems you have identified on this patient?
So I have identified some medical problems and also some social problems.
I can't hear you, Darupil. Yeah, talk it again. Tell it again.
I have identified some medical problems and surgical problems, social problems. And medical problems I have identified since this patient admitted to the hospital without labor pains. We have to induce the labor. So labor induction.
Can you present that problem more better way? Yeah, I agree with you. That is the main problem, main critical problem.
So my main problem is induction of labor.
Yeah, you can say like that. So I have identified several medical problems and some non-medical problems in this patient. My main medical problem is patient, even this is her due date, the patient has not gone into labor by her own. So, and the patient is worried about the induction of labor. That is much better because she doesn't want to stay in the hospital. So that's the reason, right? So you can say, even though this is her due date, 40 weeks, patient has not gone into her spontaneous labor and patient is worried about the induction of labor. That is your first medical concern. What are the other medical problems she is having? Any other medical problems, Daru? You can say 2, 3 more medical problems. What next?
Second pregnancy was a low birth weight
Yes.
pregnancy.
Yeah, because of the first pregnancy was low birth weight. What is the problem? Because her first baby was low birth weight, there's a possibility that this baby also can be low birth weight. Second problem. Good. What is the third medical problems? This is an unplanned pregnancy and she is elderly mother, 36 years old. What other medical problems? She is having non-food allergies, but maybe having some unknown drug allergies. So likewise, you can have several medical problems. What are the non-medical problems, Daru?
She has financial problems because only her husband is working. So she has financial issues and also she has to look after 2 kids. So she's having
no one to look after the kids at home.
um,
Okay, so she is worried about that. Okay, so and she doesn't want to stay in the hospital for a longer time because of these issues. So the non-medical issues. So you can say I have identified several medical and non-medical issues. The first medical issue is even though she is in her due date today, she has not gone into spontaneous onset of labor and she is worried about the induction of labor. Is the induction of labor is a problem? Yes. It's not the normal thing. Normal thing is the normal or natural onset of labor. Induction of labor has only complications. Okay, right. So these are the medical and non-medical problems that you have identified, Bodhini. Okay, tell me. Okay, we'll start with somebody else. Okay, Hasarangi. So I can't see only 3 of you on the screen. That's why I'm asking the questions. I'm really sorry. Yeah, Hasarangi, you tell me. Okay, this is your patient. Now you are in the exam. This is your patient. Okay. How are you going to manage this patient? That is your question in the exam. They will ask, okay, how will you manage this patient? Okay, yeah, tell me.
So since she's 36 years old and having a past history of low birth weight child, we have to manage her.
Not we, I.
Okay, I have to manage her, and I would talk to my seniors and to my consultants, and thinking about going for the induction of labor soon.
Yeah, before you talk to them, Daru, you give your view. This is my opinion. This is what I'm going to suggest. Then I will chat with my the senior colleagues and agree with my management. Yes. What will you do? If this is your patient, what will you do?
I would first talk to the patient and explain about the procedure and all the consequences. And first, I'll make sure whether she's agree with the induction of labor.
Okay, right. Now, before that, now, you know, the patient admitted at 40 weeks, right? So you don't have any ultrasound scan or anything with you at the moment, right? So now, if she has not gone into labor, next thing is you have to consider induction of labor. Now, suppose you are going to planning induction of labor. Before the induction, what are the things that you need to know about this patient?
The presentation of the baby.
Yes, exactly. You have to know the presentation of the baby. Yeah, you have first, how do you confirm your presentation?
By doing an ultrasound scan.
No, before that, you have to do your clinical examination and see whether it's cephalic and whether it is engaged or not. That is important, engaged or not. Then you have to do ultrasound scan and confirm your findings. With the ultrasound scan, what are the additional information that you can gain?
About the amniotic fluid.
Yes, you can assess the amount of Leica volume and what else?
Presentation, lie, and
placental localization, right?
Yeah.
Placental localization you can see, and as well as the presentation you can see, and the Leica volume and these things you can assess. Okay, now so suppose you have assessed everything. Placenta is on the anterior upper side, cephalic presentation, normally grown baby, and Leica is adequate. Now what are you going to do?
Then I would assess the fetal heart rate by doing CTG monitors first before we go.
Okay, right, good. Now you have assessed the fetal well-being. Baby is in a good condition. What next?
With the command of seniors and consultant, I can do
No,
that.
still you can't get their command. As a smart HO, you have to do something else and then discuss with them. Now you are planning a vaginal delivery.
Cervical assessment.
Yes, you have to do the cervical assessment. What is that called?
Sterilized vaginal examination.
What is that called collectively? Which score?
Bishop's score.
Bishop's score. That is the word we need in the exam, right? So you have to assess the Bishop's score of this patient. What are the 5 components of Bishop's score?
Cervical effacement. Cervical
effacement.
Dilatation. Cervical
consistency. Consistency.
Cervical.
Position. Station.
And
remember about those things. You can't forget your theory and go to the exam, right? So remember about. So I will do. So you have to say, first, sir, I will assess the baby's presentation and baby's well-being. So there, I would like to do the clinical examination and confirm my finding is the ultrasound scan. With the ultrasound scan, I can see the presentation, I can see the Leica volume and the placenta localization. Okay, and I would like to take a CTG, antenatal CTG, to assess the fetal well-being. If everything is okay, normal, then I would do a vaginal examination to get the Bishop's score. Okay, then with the Bishop's score, if the Bishop's score is less than 7, something like that, less than 6 or 7, is this a favorable cervix or unfavorable cervix? Unfavorable cervix. Okay, if this unfavorable cervix, patient has not gone into labor yet. Okay, suppose this patient, your patient now, she is now 40 weeks, uncomplicated antenatal period, fetal well-being is okay, unfavorable cervix. What will you do? She's 40 weeks. Yes, what will you do?
We can
Will
do cervical rightening, sir.
Okay, so are you in a hurry to deliver this baby exactly at 40 weeks?
No, but we have a concern since she's currently having some social issues of
Yes,
taking.
she wants to go home. That's the problem. Okay, she
Okay.
wants to go home, and there is no urgency to deliver this baby. Baby is antenatally uncomplicated, ultrasonically healthy baby, CTG healthy baby. So, are you in a hurry to deliver this baby now? No, you don't have to. So, how long you can wait? Up to 42 weeks you can wait. But usually at 41 weeks, we start the induction. Then by 42 weeks, baby will be out. So since the patient is not willing for induction, and since the patient is not willing to stay in the hospital for a long time, because, you know, if you start induction of labor, you can't send the patient home. And with the induction of labor, the labor patient will not go into labor in 1 or 2 hours time. It may take days. So what you have to do now? If the baby is okay,
Mother
baby
is
is okay. Yes. If
Maybe
the bishop score is unfavorable, then you can talk to the patient and you can talk with your consultants and seniors, and you can plan to discharge this patient and ask her to come back in about 5 or 6 days time to the ward. Then by that time, if she has not gone into labor, you can start the induction of labor. Okay. What are the methods? Okay. If this is your patient, what are the induction methods that you can use?
We can give syntocinon.
Straight away syntocinon. When the membrane is intact, we do start syntocinon.
Cervical ripening of, sir.
Yes. How will you do the cervical ripening?
We can give
Not we. Always say in the exam, I will do.
give ergometry.
Mage screen recording. Will you use ergometry for induction of labor or cervical ripening, Daru? Ergometry for what? For the uterine contractions in after delivery, to achieve the uterine contractions, you give ergometry. Don't mess up with now. So far you have doing well, but don't mess up with your theory, right? Refresh your theory. That's very important. So, with regard to induction of labor, now you know there are 2 methods: pharmacological method, non-pharmacological methods. What are the pharmacological methods? Prostaglandins.
Yeah,
Not ergometry, prostaglandins. You can use prostaglandins, or else you can use after ARM syntocinon. Those are the 2 pharmacological methods. What are the non-pharmacological methods? You can do ASM, artificial separation of membranes. Artificial rupture of membranes you can do. Or else you can do Foley catheter induction. That is also very effective. Foley catheter induction. So, what methods will cause more problems? Pharmacological methods, especially prostaglandins and all, can cause hyperstimulation, uterine rupture, and all these complications. Whereas non-pharmacological methods are quite safe. So, since this is a multiparous woman, 4th pregnancy, she had 2 deliveries before, the best would be non-pharmacological methods. Something like Foley catheter induction, less complicated. So you can start with Foley catheter inductions. You know how to do Foley catheter induction, Pasangi? You put the patient into lithotomy position, visualize the cervix, and insert a Foley catheter into the cervical canal and inflate the bulb. When you inflate the bulb, it will stretch the cervix and it will release natural prostaglandins. Okay, so how long you can keep Foley catheter in situ? 24 to 48 hours you can keep. You can keep maximum up to 48 hours inside. Why not more than that? Because there's a risk of infection, because it's a foreign body. So you can keep about 48 hours. By that time, most of the patient's cervix will dilate, and then you can start the ARM and syntocinon. What are the complications of induction of labor? Or then theory notes will let you know. What are the complications of induction of labor?
Patient can have postpartum hemorrhage, sir.
Failed induction. First thing is the failed induction. You do various methods, but it fails. What is the next thing? Risk of cesarean section. Failed induction and risk of cesarean section. Especially pharmacological methods that can cause hyperstimulation of the uterus, uterine rupture. Baby can die, mother can die. Risk of amniotic fluid embolism is high with induction of labor. Risk of postpartum hemorrhage is high. Risk of shoulder dystocia is high. Right? So those complications you can get with induction of labor. So likewise, Daruni, thank you, Hasangi, right? So they will go into a discussion. Now, if you have limited your history, take into 10 minutes and then summary and problem list for about 5 minutes, then you have about 10-15 minutes for your discussion. Discussion is the most important part where you can score marks. You can gain marks because you can talk. Okay. So that's how the exam is going to be. You don't have time to ask each and everything about your history and your discussion also. We don't concentrate on minor theory points, right? It's mainly practically basic things we will ask in the exam. Okay. So my opinion is that it's very difficult to fail these Viva exams. Unless you do 100% bullshit, right? Otherwise, we won't fail you in the exam, right? Don't worry. You can develop, you have to develop a little bit of confidence, then you can pass the exam. So this is how exam going to be, right? We will discuss over the time, right? Every week, like we will have this short discussion, something like this. We will take a history like the same way, and we will do the summary, presentation, and everything. Okay. So have you all had some idea about the exam, your practical exam? Right? Have you got some idea? Yes. Okay, right. So keep practicing these things. That is the only way to build up your skills, right? Keep practicing. Take your mother, take your father, or take your sister, brother, whoever the person, and get the history from that person. Okay, and try to build up your presentation skills. That is very important. You're talk. If you're not talking, then it's very difficult. Okay. So do you all have any problems, any doubts, any things? Right?
So regarding the allergic history, do we have to ask about the plasters allergies as well? Because usually
yes, you can ask when you ask about the allergies, you can ask about any food allergy, any drug allergy, any plaster, betadine. If they say any allergies, ask about plaster allergen, betadine allergen. That's good to know. Anything allergic to anything.
okay,
Okay.
thank you, sir.
Yeah. Right. So now when you're asking about the history, Daru, when was the first urine test became positive and all these blah 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 bullshits unnecessary, don't ask. They don't score any marks, that will waste your time. All right. So Bodhini, you are very good, right? This is your first day. I know that you were not prepared to get the history, but you did well, right? Within 10 minutes, you asked the history, but you have to maintain that flow, Daru. Right? Problem was with the flow, right? Continuity. Okay. So you have to maintain the continuity, right? Keep in your mind, at the back of your mind, the sketch. Obstetric history, every history has the same sketch. Okay. If the presenting complaint, there is nothing to analyze, always better to start with the past obstetric history. If the presenting history is like bleeding, abdominal pain, you have to analyze that thing there. Okay, that's how it goes. So I hope you got some idea, and we'll meet up with another session like this on next week. Okay, thank you very much for joining, and